Hi everyone, Marian Schwadler speaking. Welcome back to Biopticka Multihead seminar. We'll get a couple of cases. It's a mixture of essentially everything. My first case is brain tumor. This is quite interesting case, and it's a consult case sent for essentially for the diagnosis. The history of the patient goes back to year 2011, so it's already 15 years ago. And he was diagnosed with something, maybe treated as with the diagnosis of meningioma, and then they changed the diagnosis, and this is recurrence, current recurrence, and their diagnosis is whether it can be somewhere kind of malignant meningioma or some kind of glial tumor, glioblastoma, or sarcoma, or whatever. And we can see brain parenchyma here, and the tumor is obviously here. In addition, it shows this more like spindle cell appearance. So I had a couple of differential diagnostic considerations, including meningeal tumors, but it's not meningioma. Yeah. And we have performed methylation profiling, and maybe a little bit of ATPR here, but no like many mitotic figures were present there, no necrosis. And methylation profiling came back as pleomorphic xanthoastrocytoma, which is perfectly compatible with this histomorphology. Well, it's not like very typical textbook appearance of this kind of tumor, but this is a spectrum of how PXA may look like. So sometimes it will give you only this spindle cell morphology. Sometimes it's like more this cohesive small cell or almost rhabdoid tumor-like. And I see a couple of cases every year misdiagnosed. In fact, this is one of the most common or one of most frequent misdiagnoses in neuropathology. Pleomorphic xanthoastrocytoma diagnosed as something else, most typically as glioma, high-grade glioblastoma. And if you have a patient with a glioblastoma or some other high-grade type of tumor surviving for 10, 15, 20 years, you should do methylation profiling, and eventually, in many cases, you will find out that it's pleomorphic xanthoastrocytoma. Yeah. So this was the first case. Second case, we can do the pancreatic biopsy. This is, let's say, quite easy. It's a biopsy from a mass in the pancreas. I don't know the exact location. And you can see normal parenchyma here. So no real tumor here, but we've got something here. So sometimes you will only have stuff like this. So this is coagulum with, I cannot good focus, maybe, with some discohesive cells, with a little bit plasma cell-like appearance. And the patient is female, so this little bit broadens differential diagnosis. So with morphology like this, it can be well differentiated neuroendocrine tumor. It could be solid pseudopapillary neoplasm, and it could be acinar cell adenocarcinoma, right? So we have to apply immunohistochemistry, and this is synaptophysin staining. So this is normal pancreas here with Langerhans islets positive, and all of this discohesive population of cells is synaptophysin positive. This is not enough for neuroendocrine tumor because up to 70% of solid pseudopapillary neoplasms express synaptophysin, and this is a pitfall. So in addition, we had a little bit of chromogranin staining, maybe here. So it's obviously neuroendocrine tumor. And INSM1 staining was also positive. I stained also for Ki67 to evaluate proliferation. I tried to do grading even from these small biopsies and cytology specimens, and this was graded as well differentiated neuroendocrine tumor grade 1 because there was almost no immunoexpression for MIP1 antibody there, and I did not find any mitotic figures. Okay, so pancreas well differentiated neuroendocrine tumor. My next case is from the GIT. This is a patient with long history of IBD, inflammatory bowel disease, and ulcerative colitis. And they performed random biopsies from the mucosa. So there was no mass lesion, no polyp, nothing there, okay? And the patient, I believe, was previously diagnosed with some kind of dysplasia. And the clinical question is it dysplasia or not? So what can we see here is something with a little bit serrated appearance. And nuclei are not very atypical, but definitely are atypical. So what it is? It's not conventional type of dysplasia, but it's so-called non-conventional type of dysplasia in the terrain of IBD. Okay, so we've got several subtypes, including hypermucinous, which can look very blunt cytologically. We have dysplasia with Paneth cell differentiation, with goblet cell deficiency, or crypt cell, and the whole range of so-called serose type, which may look like a sessile serrated lesion, or something like hyperplastic polyp, or traditional serrated adenoma, or NOS. So in my eyes, it does not resemble anything. So this is probably NOS. And in the future, it will be more complicated, and there are authors like dividing this non-conventional type of dysplasia into 9 or even more categories. So yeah, it may be stupid, but there may be some subtle clinical differences. And for example, hypermucinous dysplasia, despite the fact it looks quite innocuous, the risk of progressing to carcinoma is much higher compared to conventional type of dysplasia. So I believe this patient is at very high risk of having adenocarcinoma. And if clinicians did not see anything, no polyp, no mass lesion, it's a random biopsy, the patient is candidate for prophylactic colectomy, definitely. Okay, so I believe that the gland on the right, it's very, very dysplastic. So non-conventional type of dysplasia, IBD related. this is my next case is a skin biopsy. This case is from Christina, and it's in the lumbar region, and they resected something which was already recurrent. And the question is it a squamous cell carcinoma? And at first look, it looks very busy, and it looks a little bit like well-differentiated squamous cell carcinoma. But if you follow the epithelium, it's like a very corrugated channel, and it's contiguous with the surface of the lesion. And I believe that the diagnosis is proliferating epidermoid cyst. Okay, so it's very extreme example in sacral region. So yeah, first the impression was it's well differentiated squamous cell carcinoma, but if you follow it, it's not really squamous cell carcinoma, and the epithelium is a little bit atypical, but it's mostly reactive because there's quite a lot of inflammation there, but there is no real dysplasia. This very well differentiated epithelium. Okay. My next case is consult case. This is very interesting. This is a small bowel, small intestine biopsy. Yeah. The bowel mucosa is here, and it's something eosinophilic there. Strange looking. And yeah, and the biopsy came with the diagnosis because the referring pathologist performed some immunostains, and the lesion was positive for synaptophysin, and it was positive for chromogranin. And the question was whether it could be a very rare oncocytic variant of some well-differentiated neuroendocrine tumor. Of course, it could be, but I've repeated chromogranin staining and it came that negative, okay? Synaptophysin was positive. S100, SOX10 protein negative. So I started thinking what it really is. Any suggestions?
S100.
S100 is negative. Okay, so I performed several immunos in maybe 3 rounds or 4 rounds, and eventually I had a hint from this immuno. This is melan A staining. So we've got synaptophysin positive and melan A positive lesion. By the way, cytokeratins are completely negative.
Is it adrenocortical lesion?
Yeah. So alpha inhibin was positive in addition, calretinin was positive in addition. Steroidogenic factor 1, SF1, was also positive. So this is a metastasis from adrenal cortical carcinoma.
Yeah. To small intestine.
To small intestine, yes. Yeah. With no history in the patient. Okay, so this was really tricky, and I was happy to have like Friday afternoon late the correct diagnosis finally after 4 or 5 days of really
super blunt,
hard thinking. Yeah, super blunt, and cytomorphology perfectly fits for the adrenal cortical tumor, and this oncocytic change is one of the criterion used like to predict whether it's adenoma or carcinoma. Okay, more oncocytic, it's more probable to be malignant. Okay, so not everything positive for synaptophysin and is well differentiated tumor, a neuroendocrine tumor. And my last case is it's a consult case from Slovakia. This is somewhere in the chest. I don't know the location, whether it's in the cavity or subcutaneously, because there are no normal structures present. And the tumor looks, this is very original HME. I don't have ours, but you can see that it's something which looks like really highly malignant, roundish cells with big nuclei, vesicular chromatin, plenty of mitotic figures, apoptotic bodies. And case came to me with maybe 40 immunos. So they performed essentially everything they had. And I like this kind of consult cases because sometimes you need only one or two more stains and you have correct diagnosis. And interestingly, I will show you some of these immunos because it's quite interesting. This is, for example, P16 staining. Okay, it's nice, diffusely positive, and I can tell you, it's misleading in this case completely. It's very, very misleading. P16 shows you or tells you nothing if you don't know the type of differentiation of the cell, okay? And this is EMA staining. Yeah, it's positive, yeah. Not very diffusely, but yeah, almost diffuse. EMA. And they stained for alpha fetoprotein, I believe. It's a little bit AFP positive. I don't know what to do with that. And they stained for PLAP, and it was positive. But other germ cell markers, SAL4, OCT2, were negative, so it's not germ cell tumor. So and they had also CD30. CD30 is diffusely positive. So with that immunos, you need only one or two more to like guide you.
How is ALK?
Yeah, the lesion was diffusely ALK. One protein positive, this is ALK. So EMA, CD30, ALK positive will give you the diagnosis of anaplastic large cell lymphoma, ALK positive. So to be 100% assured, I performed cytotoxic markers. This is granzyme B, and perforin was also positive, and it stained a little bit for CD4, and importantly, CD45, CD43 were completely negative. So this is one type of lymphomas where like screening marker, CD45, will not work in majority of cases. You should always have this kind of lesion in your differential diagnosis, because otherwise you will miss important diagnosis. So this is anaplastic large cell lymphoma, ALK positive. And that's it from my side.
Okay, Alena Skalova speaking. I have a very simple case just to make it more variable. This is, of course, a tumor of parotid gland. So I received this case as a consult case, and it was a large tumor, 6 by 4 by 3.5 centimeters in diameter, and the tumor was in a 74-year-old lady. And I received this tumor with a diagnosis of adenocarcinoma not otherwise specified. And as you can see in this scanning magnification, I will go very fast through the whole section, and then I'll focus a little bit more, so you can see that there is generally tubular and papillary cystic type of infiltration. I have received 20 blocks, so it was really huge tumor, relatively well circumscribed, as you can see here, but invasive. And now we can have a look at the morphology, if I make it somehow. So it's a pink tumor. You can see that the cytoplasm is relatively abundant. We may, if we want to, we may start to think about Warthin tumor, but maybe not very well, or it's very bland looking. The cells are relatively regular with the nuclei with one distinctive nucleoli. So could it be adenocarcinoma not otherwise specified? I did not want to end with this. So we performed.
Secretory carcinoma? Yeah.
Oh, secretory carcinoma, it could be, of course, but it's not. It's not.
Arsenic cell.
Any other suggestion?
Arsenic cell carcinoma.
Oh no, it does not look like this. Well, a SOX10 negative, S100 protein negative, and if you want to start to think as the referring pathologist about salivary duct carcinoma, androgen receptors negative. There was staining. I don't have immunos with me, but it was positive in abluminal layer or irregular a little bit for P63 and P40, and a little bit more of details.
How's plug 1?
Plug 1 is negative, but there is already something positive, and that's mammal 2. So FISH for mammal 2 was positive, and we performed next generation sequencing, and this is oncocytic, unusual type of mucoepidermoid carcinoma, CRTC1 mammal 2 positive. So even this could be, and if you look, I have many slides there were, and just a little bit of mucin production in these lumina, but not true mucocytes. So that's the only pitfall of this. So I believe that it's important to know that mucoepidermoid carcinoma may look like this oncocytic variant of mucoepidermoid carcinoma with a little bit, maybe here I'll be able to show you some mucin production, but not really very extensive. So, mucoepidermoid carcinoma. That's all what I have. Now it's podium is yours.
Christina?
Christina.
So I will switch to geopathology. My name is Kristina Pilovačíková, and my first case will be consult case from last week. And I got a tumor which was localized somewhere in the pelvic area, so intra-abdominal mass. And it was sent me because the original pathologist has some suggestion. It was in neighborhood of the urinary bladder, but not connected with the urinary bladder. It was not connected with it is a young patient, young lady, about 33 years old, and there was no connection to uterus, to ovary, no connection to bladder, and the suggestion of the original pathologist was about the kidney tumor. So, from the first look, you see that you have nested architecture of the lesion. The cells are with clear, abundant cytoplasm, irregular nuclei, no prominent nucleoli. So my first step was pancytokeratin staining. and it was negative. And in this scenario, the diagnosis then was absolutely straightforward. So I ordered some other stains, and the first one was HMB 45, which was diffusely positive. The lesion was focally positive for melan A. It is very weak positivity, but it is present. Very beautiful is the positivity for GPNNB, so new marker of tumors with TSC alteration on, or tumors with TFEB, TFE3 alteration, so you can see diffuse strong positivity of the tumor. And very important in this differential diagnosis is the PAX-A staining, which I don't see right now, which was negative. I'm not able to find it there fast, but I made one more stain, and this was TFE3 staining. You can see diffuse, beautiful nuclear positivity. So now we have the diagnosis. The diagnosis is PCOMA, probably TFE3 alterated. The differential diagnosis is between TFE3 alterated renal cell carcinoma and PCOMA. According to literature, the difference is in PAX-8 positivity, negativity. If the tumor is PAX-8 positive, it means that it is TFE3 translocated renal cell carcinoma. If it is negative, it is a PCOMA. So this is how these tumors are classified right now. So PCOMA of the pelvic area in a young patient. Okay, we will switch to other case. My other case will be, again, consult case from the last week, and I got a tumor from a lady about 70 years old, and okay, so first low magnification, so the tumor was relatively small. It was about, I think, 2.5 centimeters in the greatest diameter. And you can see that it is a pink tumor with focally solid architecture, and focally you can see that in other block you can more cystic architecture. Okay, so we will go closer. And you will see that the tumor is composed from cells with finely granular eosinophilic cytoplasm, which is very, very abundant. The granulation of the cytoplasms are relatively finely granular, so there is no appearance of rogue granulations, and you can see mildly irregular nuclei, no prominent nucleoli. Once again, the prominent or the architecture was solid and cystic. So from the low magnification and from this basic histology, you can have some differential diagnosis, and the first case or first diagnosis in the differential diagnosis is eosinophilic solid and cystic renal cell carcinoma. This is a tumor described, I don't know, 9 years ago by my colleague Andrea Hess here in the Pilsen. I absolutely agree this is a tumor in the differential diagnosis, but my top differential diagnosis in this case is TFEB amplified renal cell carcinoma. Why? Because of the character of the granulation in the cytoplasm. It is not enough for ESC RCC, but the overall morphology fits relatively good in TFEB altered renal cell carcinoma. So I made some immunos. So my first immuno was melan A. You can see it is positive, not diffusely, but it is positive. I made CT20. CT20 is a typical marker for eosinophilic solid and cystic renal cell carcinoma, but you can even see the positivity in TFEB amplified renal cell carcinoma relatively frequently, usually only in single cells. But here the CT20 is absolutely dead. PAX-8 was positive. GPNNB, probably you can be interested in the novel marker. So GPNNB is diffusely strongly positive which is pattern of TSC altered or TFEB altered renal cell carcinoma. So you cannot distinguish between these two modalities because eosinophilic solid and cystic renal cell carcinoma typically has alteration in TSC 1, 2, or mTOR pathway. So you cannot distinguish, so you have to go for genetics. So I made fluorescence in situ hybridization and we got a break in TFEB. So this case is a case of TFEB, translocated renal cell carcinoma. You can see very beautiful diffuse GPNNB staining. A few days ago, our study was published, have been published in the Verhoef's archive about the spectrum of reactivity of GPNNB in TFEB altered renal cell carcinoma. We know that in TFEB translocated renal cell carcinoma, the positivity of GPNNB is typically diffuse strong. But if you have a case which is amplified, so TFEB amplified renal cell carcinoma, the positivity of GPNNB is not so diffusely strongly positive. It can be irregular or it can be even with focal negativity. So it is not easy to read the immunohistochemistry in case of a TFEB amplified renal cell carcinoma. Focal positivity doesn't mean that it is not TFEB amplified renal cell carcinoma. And the GPNNB is very good marker, but it is not 100% sure about the diagnosis. So this was TFEB translocated renal cell carcinoma. And my last case, again, consult case from last week. This was a tumor from a lady about 70 years old, and I got a tumor of this morphology. So from the first look, you see that the tumor is more papillary arranged. If you are going closer, you will see that the tumor has tubulopapillary arrangement, sometimes pseudo-solid look. You can see that the tumor is composed from cells with eosinophilic cells with finely grown cytoplasm. Nuclei are irregular. You can see prominent nucleoli. Going through the tumors, you will see that there are focal accumulation. I'm not sure. There is focal expansion of the papillas by eosinophilic exudate. You can see that there are some places where the tumor is more pseudo-solid in appearance, and there were even areas probably here with accumulation of the macrophages. So this tumor has very wide differential diagnosis, starting with papillary renal cell carcinoma, going through TFEB, TFE3, altered renal cell carcinoma, FH deficient renal cell carcinoma, SDHB deficient renal cell carcinoma, to ALK variant renal cell carcinoma. So there is very wide differential diagnosis. But if you are going through the immuno, so you will see that this is FH. FH is retained the same as SDHB. You will go in the eosinophilic tumors. I relatively frequently use vimentin because I think it is very good marker in the differential diagnosis of eosinophilic renal cell tumors. So you can see that the tumor is diffusely positive. PAX8 was positive. The pancytokeratin was positive in the diffuse strong fashion. And the tumor was completely negative for melan A, HMB45, CK20, TFE3, ALK immuno, CK7 was focally positive. So going through the morphology and correlating it with the immunoprofile, you are able to make diagnosis per exclusionem, and per exclusionem this tumor is classified as papillary renal cell carcinoma. In the past, this tumor was classified as oncocytic subtype of papillary renal cell carcinoma, but now we know that the oncocytic subtype of papillary renal cell carcinoma doesn't exist. because the tumors which were grouped together into the category of causative papillary renal cell carcinoma has a spectrum of morphology, different immunohistochemical profile, different genetic background, and even different clinical behavior. So this is the reason why we don't use the category of oncocytic papillary renal cell carcinoma. And now we know that the majority of the tumors which were grouped into this category of oncocytic papillary renal cell carcinoma are in the real life other diagnosis. For example, TFEB amplified renal cell carcinoma, fumarate hydratase deficient renal cell carcinoma, and so on. Okay, this is all from me. Thank you very much.
Good afternoon, everyone. I'll finish with my cases. Basically, your weekly doses of soft tissue pathology. I'll start with some relatively easy cases, or very easy cases, as in this one. This was a 75-year-old female, tumor in the abdominal cavity, and there's just this one punch biopsy. Luckily for us and for the patient, it's a very good punch biopsy where everything we need is actually captured. Anybody besides Marion knows what this could be? Any suggestions? Don't be shy. It's really that.
It's STAT6 tumor.
Yes. So you just do basically STAT6 or CD34 if you don't have STAT6. Okay, so solitary fibrous tumor. To be able to say whether it's a low risk, intermediate risk, or high risk, you need to know the dimensions of the tumor, which I didn't. So I didn't specify, but this looks like a low risk tumor, no mitotic activity, and so on. So perfect morphology, unremarkable growth pattern, they call it patternless pattern, so there is no specific arrangement of the tumor cells, fibrous stroma, blind spindle cells, and then, although it's not specific, this hemangioperistoma-like vasculature is typically there, so if it's not there, it's much harder to make the diagnosis, but if it's there, it's much easier, along with the conventional morphology. So any location is possible for solitary fibrous tumor, even like prostate and places like that. Next case is a 64-year-old male with a tumor in the chest wall. So we get this highly infiltrative lesion, pretty dark on low power, so it seems it could be something aggressive. And here we can think about necrosis happening here, but probably not yet. But there is really bizarre atypia, which is not enough to call something a sarcoma, but when it's coupled with mitosis like that, if it's a mitosis, I don't know, it's probably it is. But there are many other like more standard tripolar mitosis. So this level of atypia or pleomorphism with mitotic activity makes it basically a high-grade malignancy. Because there are tumors which can be pleomorphic, but they don't have atypia, they don't have mitotic activity, and they can still be indolent. But here, mitotic activity, atypical mitosis, and pleomorphism means basically a high-grade tumor. So what else do we have here? So basically, undifferentiated pleomorphic sarcoma-like looking neoplasm. There seems to be adipocytic differentiation in some places, such as here. I have one more slide where it's more pretty. This is the original slide. It was more of the basically adipocytic or lipoblastic differentiation. Here it is one multivacuolated lipoblast. So there is no doubt this is tumor going into adipocytic differentiation, and the rest of it is basically UPS-like morphology. So here there are essentially two differential diagnoses. It can be either pleomorphic liposarcoma or dedifferentiated liposarcoma. So you just do MDM2 immunohistochemical staining, and that was negative with positive control. So this is a polymorphic liposarcoma. What is good to know, if you have undifferentiated polymorphic sarcoma, which is basically the same tumor without the adipocytic differentiation. So these tumors are basically the same by molecular and by epigenetic or methylation analysis. These tumors are identical. Also, clinical behavior is the same. So UPS, undifferentiated polymorphic sarcoma, is essentially the same tumor as polymorphic liposarcoma, just polymorphic liposarcoma shows areas with adipocytic differentiation. And basically the same applies to polymorphic rhabdomyosarcoma. It's again basically a UPS with rhabdomyoblastic differentiation. Again, same molecular, EC53 and RB1 mutations most of the time, complex genome, and the same methylation pattern again. Even the latest version of the Heidelberg methylation classifier doesn't specify which subtype is which one is that. It's basically one methylation group for undifferentiated polymorphic sarcoma / polymorphic liposarcoma / polymorphic rhabdomyosarcoma. Okay, next case was a 24-year-old gentleman with a tumor in his on his tongue. So this is essentially what we received, the whole thing. Very well circumscribed, small ovoid tumor in his tongue. And the morphology is really textbook example. Perfect case. Alena Skalova knows this tumor very well. Yes, Marvin knows ectomesenchymal chondromyxoid tumor, at least from the morphology. There is a very high suspicion. These tumors are usually positive with S100 protein. So we did S100 protein, was positive. And just because it's such a rare diagnosis, we did RNA sequencing, and there is indeed the RREB1 MRTFB fusion. So ectomesenchymal chondromyxoid tumor, it's pretty much indolent mesenchymal tumor, typically occurring in the tongue, but in recent years, very similar examples with the same gene fusion were described in other locations, especially in head and neck, but also in mediastinum, and we've seen cases also in soft tissues of the extremities, and one case even in the skin. So the anatomical predilection for head and neck is clear, but these tumors can be elsewhere as well. So next case is a 2-year-old boy with a small lesion on his chin, in the skin. So there's normal epidermis, of course, and in the dermis we see this funny mixture of basically skeletal muscle and nerve tissue, also some adipose tissue there. This is a very rare lesion, typical for small children. This is Desmond, just to highlight the skeletal muscle, haphazard arrangement pretty much. And here is SOX10, which nicely shows how basically the peripheral nerves are admixed with the skeletal muscle in the middle. Yeah? And so this is called rhabdomyomatous mesenchymal hamartoma. A rare lesion. It's considered a malformation or hamartomatous lesion, but I'm sure in a few years we'll find some mutation there. I actually tried, I did RNA sequencing, but there was no fusion with our panel at least. Next case is a 28-year-old lady with a tumor in the peritoneum. Okay, very cellular, pretty large neoplasm. There's quite a lot of polymorphism in atypia. There was also some mitotic activity, 3 mitoses per 10 high power fields, I counted. So mostly epithelioid, but in some areas also more spindled cells, very abundant. Cytoplasm, or here's like a mitotic hotspot, which I probably missed when I counted. And any ideas what this could be or what we should do with this? There's this nested arrangement in some places. So there was a lot of immunohistochemistry done. And cytokeratin, broad spectrum cytokeratins were negative, completely negative. S100 was diffusely positive. Then there was synaptophysin expression, diffuse. So we had INSM1 was positive nicely. INSM1, another neuroendocrine marker. Any suggestions? One more or two more markers, which I can't find right now. Okay, here. This is GATA3. And last one, FOX2B, which is a marker for neuroblastoma, but has been shown to be useful also for paraganglioma and pheochromocytoma. There is some moderate to weak but diffuse expression outside. I think this is just a weird morphology for paraganglioma or pheochromocytoma. I don't know the exact location other than retroperitoneum. There are like many scoring systems for malignancy. It's unclear which one to use, but this one looks like a malignant example based on any of these schemes, because there's high cellularity, a lot of atypia, a lot of mitotic activity, and there's also Ki67, which is kind of important for these scoring systems, which was relatively high. I think 10%, 15%. So yeah, so I think it's a pheochromocytoma potentially, or high risk, I would say, as the HB was retained. Sometimes you can see this diffuse S100 positive in some cases. Okay, next case was a 25-year-old woman with a leiomyoma diagnosis, and her myoma was removed, but there was a lot of necrosis in the tumor. If I go to the viable areas, there was no increased mitotic activity, no atypia. The patient, I think she gave birth recently, so she was undergoing some pretty major hormonal changes recently. And it was obviously sent with the question whether this is a tumor necrosis, and this should be called stump or even leiomyosarcoma, or whether it's just this hyaline necrosis associated with hormone changes and sometimes occurring in young patients. So first of all, the viable areas are important. So there is no mitotic activity, no atypia. So that's one feature against calling this leiomyosarcoma, but still a necrotic. If this was a tumor necrosis, it would still be enough to call it stump. Some authors, they suggest using two histochemical stains, basically trichrome stain, very simple method. And if you see such a severe accumulation of collagen fibers in the necrotic areas, this is more in favor of a hyaline necrosis or non-tumor necrosis, basically. Another one is reticulin stain. So this is Gemery. And in the normal viable parts, you can see this pericellular accumulation of the fibers. And if you go into necrosis, you completely lose this meshwork, basically, around the cells, which would be another feature in favor of this hyaline necrosis or non-tumor necrosis. So based on these features, I just, in agreement with the submitting pathologist, I call this just a leiomyoma with hormonal related necrosis, probably, or hyaline necrosis, non-tumor necrosis. So I rarely use histochemical stains, but in this setting it sometimes helps. Not always. Some cases are, like, you don't know how to interpret these stains, but sometimes it helps. Okay, next case. That's a fascinating lesion. Was diagnosed. It's a tumor of the stomach. The lady was 63 years old. It's from 2019. Back then she was 63 years old, and this was her tumor in the stomach. It was diagnosed here. So relatively monotonous spindle to epithelial neoplasm, lot of mitotic activity. There was necrosis, so obviously something malignant. Because we are in the stomach, there was primarily CD117 done. CD117 was kind of positive in many areas, and DOG1 was some similar pattern, maybe even less than that. So focal weak positivity, and it was called as GIST. SDHB staining was done, but was retained. So here's some DOG1 staining. And recently, the lady came back to a hospital in Prague with metastases in the liver. This is the liver metastasis. There's the liver, and look at the tumor. It looks very different from what we saw. So the pathologist who was doing this diagnosis, he mentioned that the morphology is different. He can't exclude that this is some, GIST going wild, but it looks like basically a pecoma or even alveolar soft part sarcoma, and ordered molecular testing, which wasn't done in the first tumor in the stomach. And actually there was something more. I'll show the immuno. This is DOG1, diffusely positive in the tumor. And also melan A. I don't recall if that was positive. Probably not. Or maybe focal. Yeah, focal weak expression. And GPNMB, as Christina has shown, GPNMB is marker for pecomas or tumors with this MITF activated pathway. And so the tumor was sequenced, and there was indeed KIT mutation, so the conventional GIST KIT mutation basically, but at the same time there was TSC1 mutation, which is typical for pecomas. So actually the pathologist was right with both differentials in a way. And the best, I think I agree with him, this is from Jirka Soukup, he's an amazing pathologist. He didn't send it to me for diagnosis, he sent it to me just for pleasure, just out of interest. and he wanted to see the slides from the first tumor. And basically, you can consider this a form of de-differentiation of GIST caused by the additional TSC1 mutation, which changes the morphology to basically a pecoma-like morphology. Yeah, so probably it's going to be very unfavorable for the patient, but for us it's a fascinating story. Do I have some time still?
5 minutes.
That's perfect. So this was a tumor on the finger, 70-year-old lady. It's just from routine biopsies. And so basically, you kind of feel this is going to be a mesenchymal tumor, a lot of spindle cells, not much mitotic activity, just mild atypia. And I've seen shown a few examples here at the seminar of this tumor. Often you see this mixture of these. I'll show with the mouse. These wavy, thin spindle cells, coupled with these more plump spindle cells. On this one, yeah, so very thin, elongated, wavy, such as here. And then some larger, plump, but not so long cells. And if you do immunohistochemistry, this is EMA, and it stains the thin, long, wavy perineurial cells with these beautiful long cytoplasmic processes. And you can see the cytoplasmic processes here. And then if you stain S100 and SOX10, the more plump cells will be positive. The staining is not much here, but it's diffusely positive, but it's kind of granular, not a nice one. Not a case I would photograph for a presentation, but it's a hybrid nerve sheath tumor, hybrid schwannoma perineurioma, benign lesion. Okay, this is a case I still have to sign out. And that is a young man, 18 years old, tumor in the gluteal area. We have these small punch biopsies and something really ugly is growing here. So basically small round cell tumor, this kind of nested arrangement. And obviously in this age group with this morphology necrosis, with this morphology, first of all, you should exclude Ewing sarcoma because the cells are really monotonous. And so you do CD99, which should be diffuse membranous positivity. And I'm not sure if it was here or not, probably was. So diffuse membranous positivity, which basically just says it can be Ewing sarcoma. If it's negative or not like this, you can forget the diagnosis pretty much. But if it's like this, it's not 100% sure that this is Ewing sarcoma. It just, makes the diagnosis possible. I also did DUX4 immunohistochemistry for chick ducts, sarcomas, cytokeratins, neuroendocrine markers, MyoD1, all that was done by the submitting pathologist. And also added DDIT3, which is a marker for myxoid liposarcoma. This obviously doesn't look like a conventional myxoid liposarcoma, but there is a high-grade variant of myxoid liposarcoma, which is basically a small round cell tumor. It completely loses the myxoid and adipocytic differentiation and becomes basically undifferentiated small round cell sarcoma. And here we see beautiful multifocal, very strong nuclear expression of DDIT3. Myxoid liposarcomas have fast DDIT3 gene fusion. That's why this antibody is so specific. look at the morphology. And if there is actually one more block with more tissue, and if you look more closely around here, it looks like a little bit myxoid. There are adipocytes, and you'll find also here lipoblasts. So it actually fits with the morphology. This is something I didn't take seriously, because sometimes lipoblast like cells can be formed by many things, but now I take it seriously. It aligns with, first of all, the immunohistochemical result, aligns with the small round morphology of this tumor. The location is perfect, age group is perfect. I might still think to do fish. And one last case. Okay, let's leave it for next time. So that's it. Thank you very much.